All of you are here today for the pilot provider training on ACEs screening implementation for the National Pediatric Practice Community on ACEs. And I'm Mernell Gomez. I am the Training and Technical Assistance Manager with the NPPC at Center for Youth Wellness, and we are located in San Francisco. And so with me today, I'd like to go ahead and take a moment to introduce Lena. You want to say something?
Hi, everyone. Nice to see some of your faces again, some of your familiar faces from when we were there in person in June. I'm the director of the National Pediatric Practice Community on ACEs. So thank you all for being here. We're really excited to kick this work off.
Great. Thanks, Lena. And is Carissa on?
I don't see her yet.
Okay, so we'll let Krista introduce herself as we move forward into the presentation. So as you see here, it's the slides, and we are going to be sharing this slide to you. We might make some changes, which is why you didn't get it in advance, and you will be receiving this shortly after the presentation.
Mernell, Carissa is on. Carissa, if you want to introduce yourself, go ahead.
Hi, good morning, everyone. I'm Carissa Luckett. I'm a nurse and a social worker, and I help with the training for the NPPC, and I also help with the coaching with implementation.
Great. Thanks, Carissa. Okay, so I'm just going to go ahead and be advancing the slides. If there are any questions, I know all of you are on mute. I appreciate that. You can feel free to unmute and ask a question in real time. We'll try to get to it. And then also we have a chat feature. You can also use the chat, and hopefully we'll be able to get to it in real time. All right, and then we have our contact information. So you'll see that at the end with our email addresses and phone numbers. Carissa, Lena, and I are more than welcome to, and I would love to hear from you, even post-training, if you have any questions that come up at that time. Okay. So let me just go ahead. I'm gonna just turn my camera off so you can focus more attention on the slides itself. This is the accreditation statement. It just shows how much credit you receive if you do qualify for CMEs. However, I did receive information from AHEC that if anyone is attending, they'd love to have everyone just register. So there is a separate link sent out so your leads would know what that is. If all of you can take a moment, if you haven't done so already, after the training and just quickly register, it would help out a lot. You've met the team. So our training objectives are reviewing a little bit more about the NPPC and our partnership engagement, reviewing the science of ACEs and toxic stress, orienting providers and staff to the ACEs screening, rationale, and protocol development, and discussing the screening protocol and practice with sample scripts. This section we'll probably get to on day 2. Review education tools and documentation and additional resources if applicable. So both of the last 2 bullets we'll get to more so on day 2. So let me go ahead and talk about NPPC. Before I do that, I do want to talk about the Center for Youth Wellness. So we are a pediatric organization based in San Francisco. We're focused on early childhood adversity and addressing adverse childhood experiences, ACEs, and pediatrics. We are excited to work with all of you to improve care for patients and families affected by ACEs and toxic stress, and to work to transform how the field of pediatrics addresses the issue. We will talk about how adversity plays a role in a child's life and how they can be resilient to it, and being able to predictably and compassionately be available for children will help their resiliency, and using a formal screening tool will support and evaluate how best to do this process. So the National Pediatric Practice Community, or NPPC, is a learning community of pediatric medical providers who are leaders in advancing clinical practice around ACEs and toxic stress in primary care. Our goals are to engage providers as champions on this issue, provide tools, resources, and training, coaching needed to make ACEs screening and the integration of a toxic stress framework a reality in practice. Basically, to become a hub for learning about ACEs and toxic stress as they relate to pediatric medicine. Our vision is that all primary care pediatric medical providers implement universal screening for adverse childhood experiences, ACEs, and routinely use an understanding of ACEs and toxic stress to enhance the quality of patient care and health outcomes. This project currently has a few different areas of work. We've convened a virtual community of medical providers interested in this topic, and we also provide direct technical assistance and training to medical practices to implement ACEs screening. We're having one practice teach another as it gains traction nationwide. And as of May 2019, we basically reached our goal, if not more, of 1,000 members representing 450 organizations. This is our website. It's nppcaces.org. We encourage every one of you to please sign up to get connected. So it's very easy. Just as you sign up on the sign-in sheet, just mark yes next to joining NPPC and we'll do the rest. We're a virtual network. We're committed to building a national community of medical providers using an online platform to promote shared learning, disseminate best practices, and cultivate advocates in the medical community. So all members will have access to very comprehensive online resources for tools and materials to support screening implementation. You'll also receive announcements for upcoming events such as webinars and up-to-date information from the field. We truly value our partnership. This practice has yet to adopt an ACEs screening protocol, so we provide tailored support, training, technical assistance, and coaching around all aspects of developing and implementing this protocol. We know that implementing screening can be complex, so we have the expertise and tools that can help your practice implement screening in an effective and efficient way. All right. So now that you have some context about the project, I'd like to take a moment to build a shared understanding around the science of ACEs. ACEs, or adverse childhood experiences, are potentially traumatic events experienced before the age of 18. The term ACEs comes from the Adverse Childhood Experiences Study, or ACE study, conducted in 1998 by Drs. Vincent Folletti and Robert Anda. It was one of the largest investigations ever conducted to assess connections between experiencing adversities in early life and having health outcomes as an adult. This study is the basis for the 10 core ACEs you see before you, often characterized in categories: abuse, neglect, and household instability. They include physical, emotional, and sexual abuse, physical and emotional neglect, and living in a household where a member has a severe mental illness or substance dependence, where the child has witnessed violence against the mother or parents, or where there has been separation from a caregiver due to incarceration, or shifting parental relationships, or divorce. There's additional adversities. Many ACEs screening tools for additional adversities in addition to the core ACEs. These additional adversities include hardship or significant life events, such as the death or illness of a separation or separation from a caregiver, forms of violence and bullying, and discrimination. These experiences impact a child's health in the same way as the 10 ACEs. So screening for both ACEs and additional adversities provide a more comprehensive assessment of risk factors for long-term health in a child by combining both individual and community environment level health outcomes and items. This slide shows that what the ACEs study is telling us is striking. ACEs are incredibly common among the population. So over 2/3 of the adult population has experienced at least one ACE. And we also have data that shows that nearly half of all children today have experienced at least one ACE, and that ACEs accumulate over childhood. Here's some state level data. Again, I'm only going over this briefly, but this data shows North Carolina, and you can see here that nearly 24% of North Carolina children have experienced two or more ACEs, and almost a quarter have experienced at least one ACE. We also have data that compares what a child in North Carolina who has one or more ACE may experience, both good and negative, compared to nationally. Of course, we know that while the prevalence of ACEs is common across race, gender, class, and other groups, certain groups are still disproportionately impacted. Those who might be most likely to experience ACEs may certainly find their adversity exacerbated by environmental and structural factors, such as poverty, racism, and discrimination. The ACE study and subsequent research has pointed to a dose-response relationship, meaning that the more ACEs that someone has, the greater their likelihood of negative health outcomes in adulthood, including the leading causes of death in the US: heart disease, cancer, chronic lung disease, addiction. This slide shows that those with 4 or more ACEs are twice as likely to develop heart disease or cancer and 3 times as likely to have chronic lung disease, 11 times as likely to develop Alzheimer's. So we're talking about ACEs as a potential root cause of some of our most costly diseases. But ACEs doesn't just impact health in adulthood. Many of the health and developmental concerns associated with ACEs also appear during childhood. Among infants, studies have found associations between ACEs and growth delay, cognitive delay, and sleep disruption. In middle childhood, we find associations between ACEs and asthma, learning difficulties, and behavioral problems. And in adolescence, we find associations between ACEs and violence, bullying, smoking, teen pregnancy and paternity, and weight management. So the question is, how do these early social experiences turn into health-damaging ones? What we now understand is that these early experiences act as a stressor on the body, and in doing so, activate our stress response. While this stress response is highly adaptive and generally functions well, when it is activated over and over again, it becomes health damaging. So this slide shows the spectrum of the stress response, including positive stress, tolerable stress, and toxic stress. The physiologic response to stress depends on the nature of the stressors and the availability of buffering and coping strategies. A positive or tolerable stress response is characterized by the return to homeostasis, whereas a toxic stress response may induce lasting changes. So toxic stress is characterized by prolonged or frequent activation of the stress response, caused by factors such as ACEs that leads to disruption in the way our neuro, endocrine, and immune systems work, leading to negative health impacts. So let's briefly take a look at how the toxic stress, may impact the body. So here you see some of the neurological effects that include overactivity and difficulty turning off the stress response, increases fear response, and increases risky behaviors. The immunologic effects can include increases in infections and chronic inflammation. The endocrine effects can lead to changes in hormones related to growth, puberty, and metabolism. And research has also found epigenetic effects, which includes changes in the way DNA is read and expressed, increasing risk for diseases such as diabetes and cancer. So there can also be substantial individual variability in how early adversity and toxic stress shows up over the life course. In this image, we see a few different possible trajectories as examples. First, starting at the very top, you see it's possible that an individual who experienced ACEs doesn't present any symptoms and ends up having a healthy life. Moving to the very bottom, we see an individual who experiences toxic stress. We see that disruption, which manifests as social or cognitive impairment, leading to the adoption of health risk behaviors and leads to disease or disability. These are likely individuals that those of you who are providers already identified through your practice as needing extra support or intervention. those who have behavioral symptoms are in many ways fortunate because they usually receive some sort of intervention. In the middle, we see a child who has experienced toxic stress, but perhaps doesn't present the more obvious behavioral symptoms. And maybe their symptoms are in the form of ADHD or uncontrolled asthma. So this child has no recognizable symptoms, but as an adult, they still experience premature disability or disease. This shows the importance of screening, as not one person will experience things in the same way. But we also know that some individuals do and some individuals don't experience toxic stress as a result of negative experiences. So there's a lot of individual variability. Think of it as a scale weighing the things, both good and bad, that may affect a person's health. The positive things are called protective factors, things that help create a safe and stable foundation for a child. The other end of the scale holds the bad things, or risk factors, and ACEs are risk factors. And then there's the fulcrum, the middle part. This is an individual's biology, their genes. Our biological makeup may make us more or less susceptible to stress and stressful experiences. Where the fulcrum is positioned on the scale, which would be different for every person, affects how much leverage either protective or risk factors have in shaping our life outcomes. So for example, someone who will have their scale weighed down by risk factors and is also more biologically susceptible will be at greater risk for stress-related diseases. I know I covered quite a bit of information. I just wanted to take a moment to see if there are any questions. But you know, for the sake of time, I also wanted to keep it brief. This is my section, and I'm just going to go ahead and transition it over to Carissa while folks might have some questions, and we'll just keep it on push. How's that? Carissa, are you there?
I'm here.
Okay, we'll just go ahead and move forward. Sorry, I realize we're trying to keep everything within a tight timeline.
All right. Next slide. There we go. So I'll be talking to you briefly today about how to implement successful screening. So we know a few things from our pilots that we've initiated across the country, and we've identified how and why screening in the pediatric primary care setting is an optimal venue for implementing this project. So in pediatrics, unlike most adult patient partnerships, we really see an avenue where screening and health promotion are a priority. You guys live and breathe anticipatory guidance and do it every day and very well. We see some evidence that the earlier the intervention, the more likely we are to have early detection and therefore preventing negative health outcomes. And we also see that in pediatrics, the partnership between the provider and the patient is a more robust, a more natural setting for these kinds of disclosures. Next slide. We also approach this project as a performance improvement opportunity. And so we utilize the PDCA framework. And we know that participating in a project like this can also help to meet other requirements within your practice. Those requirements around PCMH, patient-centered medical home designation, or HRSA requirements for quality improvement, or even Joint Commission requirements. And so in utilizing the PDCA framework, we will plan and identify a target population, screening interval, and then move through the do component where we implement the screening. And then we'll gather information over the next 6 months and write up a summary at the end, so that you'll have a written PDCA cycle to use for any of the requirements I mentioned earlier. Next slide. So today we are finishing up the planning component with your training, and then you'll go live and you'll start the do. And as you can see in the diagram, we'll do another couple of cycles as we work through this process and be able to track and document how things are going through your monthly coaching calls. So in setting up a successful screening protocol, we've learned a few things. One, to set a rationale for your screening. Next slide. The rationale will be something that we come back to over and over. It'll set your guiding principles for screening and help guide the interval and the population that we target as well. We also know that having a defined workflow that minimizes disruption to your practice is an important step in the screening process. Identifying the tool to be utilized, so we'll be using the ACE-Q, which you have in front of you. And we have set a scoring algorithm in conjunction with your leadership, and as part of our work when we were on site there several months ago, we helped to identify a workflow that would work well across different settings at Novant, and also be something that would mirror your current process as much as possible. Next slide. So the screening rationale that we heard loud and clear from you all was that you wanted an evidence-based intervention, and to begin screening early, and to consider care coordination and patient navigation that could help families, help get them into the right services at the right time, and identify these things through an ACEs lens. So we'll be starting to screen the 3 and 5-year-olds at new visits, and at any annual visit that you see these patients in the coming year, and then any NICU patients that are new to your program. Next slide. So this is the tool that you'll be utilizing to screen with. This will be given out to the parents for them to complete based on their perception of the experiences their child has had. We call this tool a de-identified tool, but that doesn't mean that we won't put the patient's name on it. De-identified in this context means that we are simply not asking which experiences the patient family may have had. We're simply asking them to write down the total number for each section. So the top section includes the core 10 ACEs that Marnell went over, and you can see the box to the right that asks the family to read the statements and then write the number that they've experienced in the box. The bottom section, section 2, contains more social need, more community-based events that the patient family may have experienced. And these have been identified through a community advisory panel, as well as they also align with the American Academy of Pediatrics social needs, social determinants recommendations. And so you'll add the top and the bottom sections together for a total score that will indicate the risk of the patient for toxic stress. And at the very bottom, there are some boxes that you all will be utilizing until your EHR build is finalized to track some of the key outcome measures that we will be monitoring. And that will be those patients that have refused, the patients that have a referral, patients who have symptoms present, and therefore it will change their risk factor as part of their scoring algorithm. And we'd also like to monitor patients who are already in services so that we can get a clear picture of the patients that may have a positive score but haven't been referred because they're already in services. So next slide. Here's your workflow. So we will have the medical assistant or nurse provide the paper tool to the patient family and ask them to complete it, to explain how to fill it out, which takes anywhere from about 15 to 30 seconds. The nurse or the MA will ensure that the family has completed this while they're roomed and waiting for the provider to come in. And then they'll hand off to the medical provider who will review the screener, provide any anticipatory guidance, and determine the next appropriate follow-up. Next slide. So your scoring algorithm, since we're looking at 3 and 5-year-olds and any new patients, has been set with a particular sensitivity. And so for patients who score a 0, we would ask that you go ahead and provide education related to what are ACEs and what is toxic stress. These are 2 patient handouts that we have provided for you and are actually in your packet today. For those patients who have a score of 1 to 3, but no physical symptoms or health problems, we would ask that you go ahead and provide the patient education on what is ACEs, what are ACEs, and what is toxic stress, as well as the information or any education on the protective factors and the patient handouts that correspond to that as well, which we will provide for you, as well as looking at or considering a referral to CC4C for those children under 5, and parenting resources like Triple P or Parents as Teachers, and then additional referrals as appropriate. You providers may also want to schedule a follow-up visit within the next 3 to 6 months to just monitor the child and see how they're doing with the corresponding referrals. Excuse me. So for those families who have a score of 1 to 3 but may be experiencing symptoms or a score of 4 or greater, we would continue to schedule that follow-up appointment and make appropriate referrals. And we would also link them to the social worker as well as any mental health services. And then again, schedule a follow-up within the next 1 to 3 months so that you can again monitor their symptoms related to toxic stress. So now we'll look at those symptoms and talk a little bit more about the clinical manifestations that you may see. And so as you look at this list, you may note under the inflammatory page, or excuse me, the inflammatory column where you see asthma and eczema. We are certainly not saying that asthma is a direct correlation with adverse childhood experiences. what we are asking you to consider here are symptoms of asthma, so the family that, to the best of your knowledge, is compliant with their medications and their action plan for asthma, but continue to experience uncontrolled asthma exacerbations or frequent asthma exacerbations in the context or through the lens of ACEs, where a score may be 4 or there's a significant score. We would ask you to consider these symptoms of toxic stress and overreactive immune or inflammatory response system as part of the symptoms that we typically see with those higher levels of ACEs, or that turned on immune inflammatory response, as well as a turned on neurologic response system and an endocrine response system. We also have listed here some of the unhealthy lifestyles or unhealthy coping mechanisms that we often see correlated with ACEs. So this, in combination with the ACE-Q score, would be what determines your scoring algorithm. Next slide. So you will be starting with a paper screener, which we have just looked at a moment ago. So you will print copies of the tool, review the completed forms for accuracy when the patients fill them out, document on the very bottom using the check boxes whether the patient refused, had symptoms, is in services, or you're making a referral to services. You'll then scan the documents into your EHR and file them in a manila folder so that we can track those for our monthly outcomes. Next slide. And that's the process at North Park. At South Park, the front office will, and at the Fallon Center, the front office staff will make sure that these are handed out along with the ASQ or your other process for ASQ and PSC. The medical assistants will review the forms with the patient families and hand off to the medical provider so that they can document whether the patient refused or was referred, had symptoms, etc. Then the medical assistants will scan the forms back into the EHR as you would with your other paper forms that require scanning. And then Dr. Marshall, the office manager, or whomever is assigned will sort and organize the forms into a folder to be scanned or to be tabulated and sent for your monthly data collection. Next slide. So the 4 measures that we're looking at, as I mentioned, include the percent of patients screened in a given month, the percent of patients that have a positive score, well, when you add the top and the bottom sections together for section 1 and section 2, any patients in the intermediate or high risk for toxic stress will be considered a positive. And so we'll calculate percent of positive patients screened every month. And then once we identify those patients that are positive, we'll be looking to see what patients have had the appropriate referrals, and then the percent of patients who have refused screening every month. Next slide. So we're going to take a pause here and open it up to any questions. And next week when we get together, we will be talking about your specific protocol, we'll be practicing for your specific protocol rollouts and making sure that you feel comfortable with the tool. We'll go over a couple of case studies and get into some additional meat of the project. Any questions? If you have questions, you're on mute, so we won't know that.
And our understanding is, just to be clear, the documentation piece for behavioral peds is still to be determined. And the Novant South Park, Carissa talked about sort of who the point people will be for each of the areas of documentation, so that we can collect the measures that Carissa mentioned.
Right, from developmental peds, ours will look very similar to South Park with the with when giving the form and with the CMAs, scanning it in and collecting it in a folder, and so it'll be just about the same. We have 2 different locations, so we don't have a specific CMA that will be doing that, but it will be our rooming CMAs that will handle the giving and then the scanning.
Great.
Very good. Are there any questions? Any other questions? We do have our contact information up there. I always say no one ever calls or emails me with questions afterwards, but I'm always hoping that someone will. So if there are any questions, I'm happy to take them now, or if you'd like to follow up via email. I think people are very good. Oh, do we have a question?
We can't hear it if it's being asked.
Dr. Marshall's group.
That's Dr. Donner's group.
Dr. Donner and group, we can't hear you if you have a question. Do you guys have a question?
Looks like they're discussing something, so we're just giving them a little bit of time to form a question.
How about the folks at behavioral peds? Any questions from you all?
No. I think we're good right now.
All right.
Okay.
So it looks like there's some conversations happening, but I'm wondering if they are ready. Devin, Marshall's group, any questions? If so, please unmute.
No questions.
Okay. Excellent.
All right, so if there are no other questions, again, here's our contact information. Thank you all for your time. We will see you on part 2, which is on next Monday, the 30th, same time, to cover the rest of the presentation. And then we're going to do a brief debrief of what we just discussed today, just to give you a bit of a refresher. Other than that, I guess we're done for now. So thank you again, and have a great rest of the day. See you next week.
Thank you all.
Thank you.
Bye.
Bye, everyone.